if there is a deficiency of oxygen in the body, there will be attempted physiological compensations. So the body will recognize that there is a deficiency of oxygen and it will attempt to compensate for that deficiency. So some of the clinical features that we can learn to recognize in hypoxia are caused by the body's own compensatory mechanisms. But also, if there's a lack of oxygen, this will have various effects. And again, these effects can give rise to clinical features, which we can learn to recognize. So the clinical features that we need to learn about in hypoxia are partly generated by the body's own compensations and partly the direct effects of the deficiency of the oxygen. It is the concept of hypoxia that dictates our priorities in any clinical situation. It's always A and B and oxygen first. Check the airway is clear, make sure the patient is breathing and being ventilated, and make sure they are being oxygenated. Only when these things are in place can we carry on to consider other aspects of patient well-being. A and B and oxygen first. A and B and oxygen first. They are your priorities. Hypoxia describes a lack of oxygen in the tissues of the body. So hypoxia is deficiency of oxygen at the levels of the tissues. Whereas hypoxemia is lack of oxygen in the blood. So if there's not enough oxygen in the blood, there's going to be low partial pressures of oxygen in the arterial blood. So the blood is not going to be taking enough blood to the tissues. But hypoxemia is specific to the blood. Hypoxia is specific to the body tissues. Oxygen is needed to produce energy, and all physiological processes need energy. Therefore, hypoxia will stop a tissue performing normal physiological functions. And in addition, if the hypoxia continues, tissues will start to die. And this was summed up by the English physiologist J.S. Haldane, and he said this: oxygen lack not only stops the machine, but wrecks the machinery. So Haldane was particularly talking about the brain here, because the brain is particularly prone to hypoxic damage. So oxygen lack will not only stop the brain from working, but over time it will wreck the brain. And in actual fact, oxygen lack first stops the machine from working, then wrecks the machinery. So first of all, there can be a hypoxia-induced neurological deficit. You can recognize that, intervene at that stage, restore the oxygen supply to the patient's brain, and then the machinery won't be wrecked. There will not be the neurological damage because you have intervened in a timely fashion to prevent the machinery from being wrecked. As we've noted, oxygen lack will first stop the machine, then wreck the machinery. In other words, it will cause damage to living tissues. In fact, it will kill the cells, resulting in areas of necrosis. Tissues will die if they are deprived of oxygen. So what's happening here? Well, if there's a reduction in the oxygen supply, the normal aerobic metabolism using oxygen will switch to anaerobic metabolism, which does not use oxygen. This can use up reserves in the cell, and it means that the cell can keep on producing energy for a period of time. And of course, this can be absolutely vital. Consider the myocardium, for example. If there's a high myocardial workload for a period of time, then the heart can't stop working. It has to keep on working. Otherwise, you're not going to have a cardiac output. So it can metabolize anaerobically for a short period of time. But when tissues metabolize anaerobically, they're going to produce lactic acid as a waste product, and you will get accumulation of lactic acid in the anaerobically metabolizing cells and tissues. And of course, lactic acid is just that, it's an acid. So this will lower cellular pH. In other words, the cellular environment will become acidic, and this will stop the enzymes from working, because enzymes only work in very specific temperature ranges and very specific pH ranges. So that's one mechanism that explains why the machine will stop working. But then the hypoxia will go on to damage the machine. It will cause tissue damage, and there can be damage to the DNA, the deoxyribonucleic acid, to organelles, and to cell membranes caused by the acidity. So you've got the double insult really. You've got the oxygen lack, and you've got the CO2 excess and the lactic acid excess. And the CO2 that is produced from some metabolic processes, again, that can dissolve in the tissues and dissolve in the cytosol of the cell, forming carbonic acid. So that's another acid. So there's two reasons why the cellular environment can become acidic, first interrupting physiological processes and then leading on to necrotic processes. When a cell is not getting a good supply of oxygen, it's not going to be able to produce energy as normal. And this means the amount of ATP, the amount of adenosine triphosphate in the cell, is going to be reduced. It's going to be lacking this essential ATP, energy-rich molecule to fuel physiological processes. And the sodium-potassium pump on the external cell membrane depends on a supply of ATP to energize and supply power to this pump. So as you know, normally the intracellular environment is low in sodium but high in potassium, whereas the extracellular environment in the blood and tissue fluids is high in sodium but low in potassium. And this is always going against the diffusion gradient. So all the time this ATP-based sodium potassium pump is pumping sodium out of the cell. That's going on all the time. But if there's not enough energy to power this pump, then this means that the sodium can diffuse into the cell, but there's no energy to pump it out again. So the amount of sodium inside the cell will increase. And because sodium is an osmotic molecule, the amount of water will also increase inside the cell. So the cell is going to have a lot of sodium, that's going to attract a lot of water, and that's going to start to blow the cell up, and the cell will swell. This is called cytotoxic edema, and it's particularly noted when there's lack of oxygen supply to the brain. You get this cytogenic, cytotoxic cerebral edema when the glial cells and to some extent the neurons swell up. So cytotoxic cell damage. So when cells are hypoxic, when any cell is hypoxic, the sodium inside the cell will increase, therefore the water will increase, therefore the cell can blow up, which of course is not a physiological situation. If a cell fills up with enough water, then ultimately that can burst the cell membrane, causing lysis of the cell. And as well as that, there's going to be injury to the lysosomal membranes and the external cell membranes. So if you remember the lysosomes, which contain digestive enzymes like lysozyme, very important in phagocytosis and apoptosis. But if the membrane to the lysosomes are damaged, then this can release the lysozyme and other digestive enzymes into the cell. And of course, they will simply digest the proteins and other biomolecules inside the cell, obviously causing death of the cell. And actually, in most tissues, there's a fine line between reversible and irreversible hypoxic damage. So when there's hypoxia, you're going to start getting these hypoxic cellular changes. But if you restore the oxygen supply, all of these changes can be reversed. But in some tissues, maybe it's just a matter of a few seconds later, the hypoxic damage becomes irreversible. You could get necrosis in some tissues, and the lysosomal cell membranes could be damaged, releasing the lysozyme into the cell, which is clearly an irreversible situation. So again, clinically, this is of massive importance that we intervene as early as possible in any cases of hypoxia to individual patients or indeed to parts of the body. It's important for us to notice that different tissues have different degrees of susceptibility to periods of hypoxia. Some tissues are very intolerant of any degree of hypoxia, whereas other tissues can tolerate hypoxia for some period of time. Now, you'll see different figures quoted for the central nervous system. Some people say that CNS damage can occur after 1 to 3 minutes. Now, that's true if there's a complete deficiency of oxygen to the neuron. It can be damaged after 1, 2, or at most 3 minutes. But in practice, there's a reserve amount of oxygen in the tissues of the body, and there's a reserve amount of oxygen in the blood. Of course, if that blood is not circulating, that reserve will be used up locally much more quickly. So in a cardiac arrest, where there's complete disruption of circulation and therefore oxygenation to the central nervous system, we do get very worried after 3 minutes. But there's probably not going to be significant neuronal deficit for 4, 5, or 6 minutes. And interestingly, the myocardium is approximately equally sensitive to hypoxic damage. Now, tragically, I've heard people say we didn't try to resuscitate this person because they'd been unconscious for so long that they would have severe brain damage. Now, there's a fundamental flaw in that type of thinking, because if you can get the heart started again, then the myocardium was not irreversibly damaged by the hypoxia. And if the myocardium was not irreversibly damaged by the hypoxia, then the central nervous system would not either be irreversibly damaged by the hypoxia. So in very many situations, if you can restart the heart, the brain is actually going to be okay. Now, I'm not saying you can't get brain damage after cardiac arrest. You most certainly can, especially an out-of-hospital cardiac arrest. But, it's still a viable principle that if you can restart the heart, then there's a reasonable probability that the brain will be intact. And that is especially true these days, where we can give patients hypothermic cooling therapy in the 24 hours after an out-of-hospital cardiac arrest. Now, kidneys are fairly sensitive to hypoxia, 10 to 20 minutes, and liver probably even more sensitive at around about 10 minutes. And this has great implications for people that are involved in organ transplantation. Now, skeletal muscle and skin is very hypoxia tolerant. It can manage without a blood supply and still be viable after an hour or two. And this is very useful in orthopedic theatre, for example, where we can exsanguinate a limb with rubber tubing or whatever you want to use to squeeze the blood out of a limb, then put on a tourniquet, and we can leave that tourniquet on for quite a long period of time while orthopedic surgeons work on the limb. We can't leave it on for too long. And of course, when the tourniquet is released, we have to account for the fact that there can be a bolus release of toxins from the tourniqueted limb back into the circulatory system. but it nevertheless remains true that skeletal muscle and skin can remain viable for some time without an apparent oxygen and blood supply. The idea that hypoxia first stops the machine, then wrecks the machinery, is true of the myocardium, and there's an important clinical implication of this. So if someone is in a cardiac arrest situation, the myocardium itself is not going to be perfused, therefore the myocardium itself will become hypoxic. Now, if the myocardium is hypoxic, eventually it will be damaged and there will be hypoxic necrosis and death of the myocardial tissue. But well before that point, the hypoxia will interfere with the functioning of the myocardium. The myocardium won't function. So that means if someone, for example, is in fine ventricular fibrillation, that may be resistant to defibrillation because the myocardium is hypoxic, because oxygen lack first stops the machinery. The myocardium can be non-functional. And people who work in emergency care have long known this, because they say blue hearts don't start. In other words, if the patient is cyanosed, if they have a blue heart, that heart won't start. So what it is necessary to do is to oxygenate the myocardium prior to defibrillation attempts. And we can do this. If the equipment is available, the patient can be intubated and they can be oxygenated with 100% or as near 100% oxygen as we can get, and that will put oxygen in and out of the lungs. But of course, the fact that there's oxygen in the lungs doesn't mean that oxygen will get to the myocardium. It won't unless we instigate an artificial circulatory system with chest compressions. With chest compressions that are well done, with good chest compressions, we can get something like 30% of normal cardiac output. And that's going to circulate blood around the myocardium, and that's going to oxygenate the myocardium, relieving the hypoxia in the myocardium, getting it back into a physiological situation where it is startable. It may then start again. So it's another example of the principle oxygen lack first stops the machine, then wrecks the machinery. And we can get the machine working again by oxygenating it. We can then defibrillate the myocardium, restoring sinus rhythm, and then the cardiac output will go from 30% from our chest compressions back up to 100% because, again, the patient is enjoying a physiological sinus rhythm-based contraction of the myocardium. The clinical features that we need to learn to recognize in hypoxia have two causes. Firstly, the clinical features can be caused by the body's own physiological compensations as it tries to compensate for the current deficiency in oxygen. Or the other group of clinical features can be caused by the hypoxia itself. So we need to look for the body's physiological compensations, and we need to look for the actual effects of hypoxia itself. These are the two causes of the clinical features. So we're going to start off by looking at the physiological compensations, but to do this, first we need to look at a bit of underlying physiology. The levels of oxygen in the blood are monitored on a minute by minute, indeed really a second by second basis. So detectors in the body called chemoreceptors are monitoring the amount of oxygen in the blood on a second by second basis. And if the amount of oxygen in the blood drops, this is obviously an immediate danger to the body. So the chemoreceptors will immediately alert the brain. And the brain, particularly the medulla oblongata in the brain stem, will bring about physiological compensations. So hypoxemia is immediately detected if it should occur. and there can be physiological compensations to compensate for the hypoxemia. As we see on this diagram, the carotid bodies are located between the internal and the external carotid arteries, just above the bifurcation from the common carotid artery. And despite being very small, they have a high blood supply from the external carotid artery. So as you can see, there's a little arterial branch between the external carotid artery and the carotid body. This means they're getting arterial blood straight from the external carotid artery. And this allows the sensitive cells in the carotid bodies to detect any reduction in blood oxygenation. If blood oxygen levels fall, this information is sent to the medulla oblongata of the brain stem via sensory nerve fibers of the glossopharyngeal cranial nerve. The chemoreceptors are tissues which are sensitive to the levels of oxygen in the blood. And there are chemoreceptors scattered along the underside of the arch of the aorta, and these are called the aortic bodies. So the aortic bodies are chemoreceptors located in the arch of the aorta. And in addition, as we saw in the previous slide, there are two carotid bodies, one located at the bifurcation of each of the common carotid arteries. So the carotid bodies are also chemoreceptors. And these aortic and carotid bodies are called peripheral chemoreceptors, as opposed to those in the medulla oblongata of the brain stem, which are classified as central chemoreceptors. But the central chemoreceptors are not sensitive to the amount of oxygen, they're sensitive to the amount of carbon dioxide. It's these peripheral chemoreceptors in the aortic arch and the carotid bodies that are sensitive to the amount of oxygen. And peripheral chemoreceptors are particularly sensitive to oxygen lack. And their anatomical position, the anatomical position of these oxygen lack chemoreceptors under the arch of the aorta and near the carotid arteries, allows the blood circulating towards the brain to be sampled. So if there's a lack of oxygen in the blood going to the brain, this will be rapidly detected and can be compensated for, maintaining the oxygen supply to the brain, which of course is absolutely vital. When oxygen lack in the blood is detected, the chemoreceptors are stimulated. And this in turn sends nervous messages to the cardiac and vasomotor centers in the medulla oblongata of the brainstem. These medullary centers initiate sympathetic activity. There is increased sympathetic outflow, and this increases cardiac output and causes peripheral vascular vasoconstriction. And both of these measures will also increase blood pressure. These effects mean that because the cardiac output is increased, the red cells are circulating more rapidly between the lungs and the tissues, and so may deliver more oxygen to the tissues in a given amount of time. So even if the patient suffered a hemorrhage and there are less blood cells present, the blood cells that are present are circulating more quickly, so this is a compensatory mechanism. Impulses from the chemoreceptors stimulated by oxygen lack will also stimulate the respiratory center in the medulla oblongata of the brainstem. And this will cause increased sympathetic outflow, which will affect the respiratory system. So this can increase the stimulation of the intercostal muscles and the diaphragm. And as well as that, sympathetic stimulation will cause bronchodilation. So the bronchial passages will be wider, allowing more oxygen to enter the lungs if that oxygen is available in the external environment. If you take an oxygen saturation probe and put it on your own finger, you'll probably get a reading of something like 98% oxygen saturations. Then if you take a breath and hold your breath and stop breathing for a period of time, in most people after about 20 seconds they get quite a strong desire to start breathing again, and after 30 or 40 seconds the desire is getting pretty strong, and for most people by the time they've stopped breathing for about a minute the desire to breathe becomes absolutely overwhelming. But if you look at your oxygen saturations during this time, you'll find out that they don't drop off. So you can be absolutely desperate to take a breath and yet your oxygen saturations can be 98%. The reason that you're feeling the desire to breathe is not because the levels of oxygen in the blood are going down, but because the levels of carbon dioxide are going up. And this is stimulating the medulla oblongata, which is very sensitive to the levels of carbon dioxide in the blood. And it is this increased level of carbon dioxide that is stimulating the desire to breathe. And for most people it becomes overwhelming and they have to start breathing before their oxygen saturations drop off. Now, I'm not recommending you do this, but I have seen it done. You can have seen people take a breath and hold their breath, and they keep holding their breath until their oxygen saturations start to drop off. And when the oxygen saturations do start to drop off, they drop off very rapidly indeed. So the desire to breathe is stimulated by carbon dioxide excess rather than oxygen lack in healthy individuals. The flow of oxygen from the lungs to the tissues is described as oxygen flux. So it's the amount of oxygen transferred to the tissues each minute from the lungs. So the oxygen flux is telling us how well the body is delivering oxygen to the tissues. Now, the oxygen flux depends on the amount of blood pumped out by the heart in a 1 minute period, that's cardiac output, but it also depends on how saturated the hemoglobin in the blood is, and it also depends on the amount of hemoglobin in the blood. So really these are the three main factors: cardiac output, arterial oxygen saturation, and hemoglobin saturation. So it follows that if there is a reduction in any of these parameters, there's going to be a reduced oxygen flux, therefore degrees of tissue hypoxia. So if cardiac output is reduced, or arterial oxygen saturation is reduced, or hemoglobin concentrations are reduced, all of these can lead to hypoxia. But it also follows that if these are increased, then the hypoxia can be ameliorated. We can reduce the level of hypoxia by compensating. So by increasing cardiac output, by increasing arterial oxygen saturation, or by increasing hemoglobin concentrations, we can increase oxygen flux. Now this 1.34 number is quite special. It describes the volume of oxygen in mils of oxygen carried by 1 gram of hemoglobin. So what this means is we can actually work out the oxygen flux in terms of mils of oxygen per minute going from the lungs to the tissues of the body. We'd have to take cardiac output in litres per minute, and the oxygen saturations we would have to take in millimeters of mercury, and the hemoglobin concentration we'd take in grams per deciliter. So if you actually work all that out, it gives you around about 1,000 mils of oxygen. That's 1 litre of oxygen that the blood is able to transport from the lungs to the tissues in a 1 minute period. Now actually only about 25% of that oxygen is consumed by the tissues, because we know that the arterial oxygen saturations are near enough 100%, but the oxygen saturations in venous blood are normally around about 75%. So of this 1,000 mils of oxygen, which is transported from the lungs to the tissues in a 1 minute period, at rest about 250 mils is actually utilized. So let's assume we have a severely injured patient who's lost over time 50% of their blood volume. Now we can replace that volume, as the guidelines for ATLS suggest we should, with Hartmann solution. So that means that the patient can now be euvolemic, that is, the patient is no longer hypovolemic, but because they've only got half as much blood as they used to have, the hemoglobin concentration will be halved. So because we've replaced blood volume with Hartmann solution, the hemoglobin concentration is halved because the patient now only has approximately half as many red blood cells as they had before. Without further compensation, oxygen flux will therefore also, roughly speaking, be halved. And that's not a good situation. It means the tissues are only getting half as much oxygen as they used to. But because of the chemoreceptors stimulating the medulla oblongata and the compensatory effects, there will be a cardiorespiratory compensation. This will happen. And it will increase cardiac output. So if cardiac output is doubled, then in theory this will return the oxygen flux to normal, because each red blood cell is going around twice as quickly. So the overall amount of oxygen going to the tissues, in theory, would be the same. And interestingly, this also explains why people with chronic anemia do have a tachycardia. So if patients have chronic anemia, one of the clinical features of that is the tachycardia. Well, obviously we can help the patient's compensations by increasing the saturations of oxygen, by giving additional oxygen. So by increasing FiO2, the inspired concentration of oxygen, we can help the patient's respiratory response. And we can also greatly accelerate the red cell response by giving patients blood transfusions. So when patients have lost a significant amount of their blood volume, we can increase the oxygen flux by increasing the hemoglobin concentrations by giving blood transfusions. In the more chronic situation, we can give patients hemotinic drugs to improve their ability to make their own hemoglobin, to make their own red cells. We can give iron and vitamin B12 and folic acid and protein and things that will help the patients make their own red blood cells. But of course, this response will take several weeks to develop, whereas a blood transfusion will work within an hour or two. Now, as we've noted, hypoxia will stimulate the peripheral chemoreceptors. That will feed back to the medulla oblongata, and there the respiratory center will increase the neuronal outflow to the intercostal muscles and to the diaphragm, increasing respiratory effort. But the problem is we don't normally see this, because in normal situations it is the hypercarbia or the hypercapnia, both mean the same thing, the increase in carbon dioxide in the blood that's going to stimulate the respiratory effort. But in experimental situations, if you hold the level of carbon dioxide in the blood at low levels, but induce hypoxia, for example, in an anesthetized animal, so they have low levels of carbon dioxide in the blood, but they have hypoxia as well, then respiration will be stimulated. So the hypoxic drive can stimulate the respiratory center and stimulate respirations independently of the levels of carbon dioxide in the blood. It's just that in health, the levels of carbon dioxide in the blood, as they increase, will stimulate respiratory effort before the individual, or at least the healthy individual, becomes hypoxic. Hypoxia will induce an increased sympathetic outflow from the medulla oblongata. This will result in increased heart rate and stroke volume, so there'll be a tachycardia. There'll also be a peripheral vasoconstriction, because any blood that is able to carry oxygen should be conserved for the internal vital organs like the myocardium and the brain. So there's peripheral vasoconstriction, but that's also useful for us because we can notice pallor. The patient can be pale as a clinical feature of hypoxia. The increase in heart rate and the peripheral vasoconstriction will together generate hypertension, because you might remember that blood pressure is cardiac output multiplied by peripheral resistance. And what this means is that the blood that is present, the red cells in that blood, are circulating twice as quickly, or certainly circulating more quickly than they would be normally because of the increased cardiac output. So any oxygen that is present can be circulated to the hypoxic tissues as rapidly as possible. Now, because there's increased sympathetic activity, that can also cause sweating as well. So the patient may also be wet and sweaty. These are attempted cardiovascular compensations that will occur physiologically in hypoxia. It is, of course, vital that the brain receives a constant oxygen supply, or there will be disruption to neurological function, followed by neurological deficit, as the hypoxia damages the neurons. And when the amount of oxygen in the brain drops, the brain responds to this by initiating a cerebrovascular vasodilation. In other words, the brain increases its own blood supply. And if the brain increases its own blood supply, that means there'll also be an increased oxygen delivery to the brain. So the brain is very clever here. It's auto-regulating its own blood supply. And when the amount of oxygen drops, it will dilate its own blood supply. There will be cerebrovascular vasodilation that will increase the blood supply to the brain and hopefully increase the oxygenation of the brain, therefore maintaining cerebral function so that effective action can be taken to reverse, hopefully, to reverse the cause of the hypoxia. One of the clauses in the oxygen flux equation is arterial oxygen saturations. And we can increase arterial oxygen saturations by increasing the amount of oxygen in the alveoli, and this can be achieved by increasing the rate and volume of respiration. It can also be aided by sympathetically induced bronchodilation. So tachypnea is an attempt to increase the oxygen saturations in the blood. We can aid this, of course, by giving supplementary additional oxygen to further promote the level of oxygenation of the alveoli and hence the blood that is achieved by any particular level of patient respiratory effort. Hemoglobin concentration is one of the components of the oxygen flux equation. Therefore, if there is a deficiency of oxygen getting to the tissues, this can partly be compensated for by an increase in the amount of hemoglobin in the blood, because it's the hemoglobin that actually carries the oxygen. And of course, the hemoglobin is present in the red cells. So hypoxia will generate a red cell response. We need more red cells, so there's more hemoglobin, so there's an improved oxygen carrying capacity of the blood. So the endocrine hormone erythropoietin is primarily produced by the kidney, but some is produced by the liver. Now, normally about 90% of the circulating erythropoietin is produced by the kidneys, and the remaining 10% comes from the liver. In chronic renal failure, the 10% of erythropoietin produced by the liver is insufficient to stimulate normal erythropoiesis. You won't get the stimulation of the production of enough erythrocytes. There will not be enough red cells, because in chronic renal failure, all of the kidneys not working properly, so the kidney is no longer producing the erythropoietin. And as you would expect, this results in the development of anemia, which can be severe. Now, in the old days, we used to give blood transfusions to patients with chronic renal failure to get the hemoglobin up. But these days, although erythropoietin is a large glycoprotein, it is available in injectable form. And when given to patients with renal failure, the bone marrow is stimulated to produce normal amounts of red blood cells, thereby curing the anemia without the necessity for blood transfusions and the complications which can be associated with that procedure. The kidneys are able to detect the amount of oxygen in the blood which is passing through the kidneys at any one time. Now, if this level of oxygen drops, the kidneys respond by releasing erythropoietin. And erythropoietin circulates in the blood to the bone marrow, where it stimulates the process of erythropoiesis. And erythropoiesis describes the production of new erythrocytes, that is, the red blood cells. And as we've said, this cell-forming process takes place in the red bone marrow. And once formed, the new erythrocytes are released into the systemic circulation. Now, if the number of red cells in the blood in the systemic circulation is increased, this will increase the oxygen carrying capacity of the blood. And this in turn will result in increased levels of oxygen in the blood perfusing the kidneys. And when the levels of oxygen in the renal blood supply are increased, this will again be detected, and the kidneys will respond by secreting less erythropoietin. And this regulation of the secretion of erythropoietin is the main mechanism which controls the number of red blood cells in the circulation at any one time, and therefore it's going to influence the oxygen carrying capacity of the blood. If we go and live at altitude, there will be lower partial pressures of oxygen in the air. That will mean that the levels of oxygen in the blood also drop. That will be detected by the kidneys. That will stimulate the erythropoietin mechanism, and over time, over days and weeks, that will increase the number of red cells in the circulation, increasing the overall amount of hemoglobin in the circulation, thus helping to compensate for the altitude-induced hypoxia. This is why athletes often go and train at altitude. They'll get more red blood cells, they'll get more hemoglobin, and that will improve their aerobic capacity. This is a picture of Lance Armstrong, and he won the Tour de France, the world's toughest cycle race, no less than 7 times. A totally amazing achievement. But the problem was he and his teammates were injecting themselves with EPO, erythropoietin, the synthetic form of erythropoietin. And this was stimulating their erythropoiesis. It was increasing the production of erythrocytes, so he had many more red blood cells and therefore more hemoglobin in his circulation than he would normally have. This meant he was able to deliver oxygen from his lungs to his tissues in a much more efficient way. It increased the oxygen carrying capacity of his blood, and this therefore greatly increased his aerobic capacity, meaning he could cycle longer and faster than other people. And of course, it's cheating. It's completely unacceptable. The problem was with cycling at that time, a lot of people were taking drugs. And it doesn't alter the fact that Lance Armstrong's probably one of the greatest cyclists that the world has ever seen. It's just such a great pity that he needed to, or felt the need to cheat in this way, because he could probably have won if the field had all been clean anyway. I guess the problem is we'll never know, will we? That's the problem. So we've mentioned the main well-known changes that occur as a result of hypoxia: the rapid adaptation of the cardiovascular system, the rapid adaptation of the respiratory system, the slower adaptation of the increase in the number of the red cells. These are well known and they're part of the oxygen flux equation. But there's also numerous other adaptations will take place in response to hypoxia, but these usually take time to develop. Now, if a tissue is hypoxic locally, if a systemic tissue is hypoxic, then there will be a vasodilation to that area to increase the blood supply and to try and increase the oxygen supply. And over time, there will be growth of new capillaries and new blood vessels into a hypoxic tissue. So there can actually be a physiological compensation in the initial instances with vasodilation, followed by an anatomical adaptation where you actually get more blood vessels. If muscles are chronically exposed to hypoxia, for example during training, during aerobic training, then there'll be an increase in the amount of myoglobin, and the myoglobin will store oxygen within the muscle itself. And there's numerous intracellular changes which science is only just beginning to understand in adaptations to hypoxia. So throughout your career, keep an eye on this field. It's a rapidly changing one, lots of new science is being discovered, and it shows the amazing ability of the body to adapt to low levels of oxygen. But the key thing with these changes is they take a long time to develop. In the acute situation, hypoxia is immediate and life-threatening. In the chronic situation, the body has amazing powers of adaptation, but they do take time, and we're talking days, weeks and months rather than seconds, minutes and hours. Well, we've been looking at the way the body compensates to being hypoxic. Next, we want to consider the pathophysiological consequences of hypoxia, because of course we're dealing with a deeply pathological situation if the patient's not being oxygenated. And pretty well all of these pathophysiological consequences that I can think of are a nuisance. We need to account for them as far as we can, but they will damage the integrity of our patient's tissues, they will cause injury, and of course they will cause death. But the first one I want to deal with is actually quite useful to us because it's a kind of safety net for us. Now, hopefully we'll notice if a patient is becoming hypoxic really very quickly, because we'll be monitoring their pulse oximetry and we will be observing our patients very carefully because we don't want them to become hypoxic. But if we do slip and the oxygen saturations do start to drop, and if the oxygen saturations start to drop into the 80s, certainly if these saturations get down to about 85, then the patient will warn us by becoming cyanosed. So the first one we want to talk about, it is a pathophysiological consequence. It's an abnormal situation, but it's also useful because it means we can detect if our patient's becoming hypoxic. So first of all, let's think about cyanosis, and then we'll think about some of the ways that hypoxia can interfere with the functioning of the machine, and some of the ways that hypoxia can damage the machinery. Cyanosis describes the blue discoloration of the skin and mucous membranes seen as a result of hypoxemia. So what's going on here? Well, if the oxygen concentrations in the hemoglobin drop, we know it becomes dark red in colour. So deoxygenated blood is dark red. And when the human eye looks at this dark red discoloration through the skin, the human eye perceives that not as being dark red, but as having a bluish, purplish tint. So really, it's sort of an optical illusion, really. It's the way the eye perceives dark red colours through the skin. But we need to know that the cyanosis is the discoloration caused by the hypoxemia. So when we see cyanosis, we know that the oxygen concentrations in the blood, in the tissues we are looking at, is reduced. So it's a very important clinical observation. Cyanosis normally becomes clinically apparent when the oxygen saturations drop below 85%. So in a sense, this means we've already failed because we haven't kept our patients' oxygen levels in the desirable range. So when we see this blue discoloration, we think, oh dear, oxygen saturations are below 85%. Time to get them up again. Here we see an example of fairly extreme peripheral cyanosis occurring in Raynaud's phenomena. Now, what's happening in Raynaud's is that there is excessive peripheral vasoconstriction, usually in response to cold. So when it gets cold, there should be peripheral vasoconstriction to keep the warm blood near the core of the body. But in Raynaud's phenomena, that is grossly exaggerated. And even with a little bit of cold, there is a great reduction in the blood supply to the periphery, in this case to the fingers. Now, because there's a reduction in blood supply, that means that the blood that is going through the fingers is going through much more slowly. And that means that much more oxygen from that blood is taken from the blood into the tissues because there's more time for the oxygen to be transferred from the blood into the tissues. And as a consequence, that means the saturations of oxygen in the blood that is in these tissues is greatly reduced, and that's what gives rise to the cyanosis. So we can see cyanosis in fingers, sometimes in toes. We can also see it in earlobes because they're actually fairly peripheral in the earlobes and in the pinna of the ears sometimes. And it's caused by reduced rates of circulation through the tissues, resulting in localized deoxygenation of the blood. So this can be a concern for the tissues that we're examining, but it often does not mean that the patient is hypoxemic systemically. Therefore, we would usually consider this to be less serious than central cyanosis. This patient was admitted with severe peripheral cyanosis. This could be caused by a localized circulatory deficit. It could be caused by some systemic cause of hypoxia, or it could be caused by circulatory deficiencies. So we need to examine the patient in more detail to work out what the underlying cause of this cyanosis is. Here we notice the patient has significant cyanosis in their right foot. Now what has happened here is there's been an acute arterial thrombosis in one of the large arteries supplying blood to the leg, and that means the foot has become acutely ischemic. So the blood that is going through the foot is only going through very slowly, giving the blood lots of time to deoxygenate, giving rise to this cyanotic appearance. And of course, we'd also assess this limb for the other clinical features of an acutely ischemic limb. And this is sometimes described as the 6 Ps. So we would check for pain. On the rest of the leg there can be pallor, a white colour, but then it can often go mottled. If the arterial insufficiency is severe, the limb can become pulseless or certain pulses can vanish. There will be paralysis in that the patient will usually have an inability to waggle their toes. And there can be paresthesia leading to anesthesia with loss of touch sensation. So pain, pallor, pulseless, paralysis, paresthesia. And the last one's a bit of a cheat, but it's still a P. It's perishing cold, because there's not enough blood going through the limb. The limb feels cold. Now, while peripheral cyanosis can be a clinical feature of peripheral ischemia, and not necessarily a clinical feature of hypoxemia, With central cyanosis, it's different. Central cyanosis is a clinical feature of hypoxemia, and you're not going to get significant central cyanosis until the oxygen saturations are down to about 85% or lower. So central cyanosis is a very important clinical feature. And as we've already mentioned, it actually means that we have already failed because we don't want our patients' oxygen saturations to be as low as that. And central cyanosis means cyanosis near the center of the body, as the name implies. So the lips, the tongue, the face, the neck, the chest, if these areas are exhibiting cyanosis, this is central cyanosis, and it's a feature of hypoxemia, as opposed to the peripheral cyanosis, which can be a clinical feature of ischemia. Well, a congenital heart disease is a heart disorder which is present at birth, and these are usually anatomical in nature. For example, you probably know that during fetal life, there's a communication between the right atrium and the left atrium called the foramen ovale, and this is supposed to close off at birth. But if it doesn't, and you end up with a patent foramen ovale, that means there can be communication between the blood in the right and the left side at the side of the heart, meaning that deoxygenated blood, or at least partly deoxygenated blood, can be pumped into the systemic circulation, causing central cyanosis. Or you may have heard of the ductus arteriosus. The ductus arteriosus is a communication between the aorta and the pulmonary artery. And again, that's supposed to close off at birth. And if it doesn't, you're left with a patent ductus arteriosus. And again, this means there can be communication between the aorta and the pulmonary artery, again, reducing the efficiency of the heart-lung circulations and the separation of blood between the right and the left side of the heart and the major vessels. Well, here we see an example of finger clubbing, and this occurs when the amount of soft tissue beneath the nail bed increases. Now, it's not entirely clear why this happens. It might be related to the levels of protein that stimulate blood vessel growth. But clubbing of fingers can be associated with chronic hypoxia, or at least chronic lung diseases. So it can occur in lung cancer, lung abscesses, pulmonary fibrosis, bronchiectasis, but it's not usual to find it in pneumonia, asthma, or really much in COPD, so it's a bit strange really. But it can also occur in heart disease, some congenital heart diseases, some liver diseases, and occasionally it can be inherited. And it's not of any great clinical significance itself, it doesn't need treated, but it can be a sign of underlying heart or lung disease. Carbon monoxide poisoning can be acute or develop in a more chronic pattern. Now, there's many tragic deaths, unfortunately, from acute carbon monoxide poisoning. For example, there can be malfunctioning of a gas fire or a gas boiler, or someone could have the remains of a barbecue burning inside the tent. They might take the remains of a barbecue inside the tent to keep them warm, but then it smoulders in the night and gives off carbon monoxide, and that can result in death. Other times it can be a more insidious process if there's smaller amounts of carbon monoxide getting into the atmosphere. Usually there's going to be headache, nausea, breathlessness and collapse, and dizziness can develop. And sometimes, unfortunately, the patient just feels very sleepy, and they'll think they're sleepy, so they'll lie down and have a nap. But unfortunately, it can be a nap from which they do not wake up. So carbon monoxide is odorless, it's invisible, but it's also deadly poisonous in higher concentrations. When carbon monoxide is inhaled, it will bind onto the hemoglobin in the red cells, forming carboxyhemoglobin. And when the hemoglobin oxygen carrying sites are blocked by carbon monoxide, in other words, when the hemoglobin is in the form of carboxyhemoglobin, then there are no spare carrying sites for the oxygen, and the hemoglobin becomes unable to carry the oxygen. This means the red cells will circulate as normal. They'll go from the lungs to the tissues and from the tissues back to the lungs, but they won't be able to carry the oxygen. So the whole circulatory system becomes completely pointless, and the tissues will become hypoxic as a result of the presence of the carboxyhemoglobin in the blood. And the pulse oximetry probes that we use cannot differentiate between carboxyhemoglobin and oxyhemoglobin. So you can actually get someone, for example, who survived a fire where they've inhaled carbon monoxide, or perhaps someone who's been trapped in a garage with a motor vehicle exhaust which has been running, a motor car has been running, probably through a suicide attempt or sometimes just through accident. And you can put the oxygen saturation probes on that person's finger and it might read 98, 99 or 100%. But that doesn't mean that the tissues are getting the oxygen, because the probe may well be picking up the carboxyhemoglobin rather than the oxyhemoglobin. So in patients that are likely to have inhaled carbon monoxide, we have to have a high suspicion for the presence of carbon monoxide poisoning. So we can't diagnose carbon monoxide poisoning using pulse oximetry. We can get some intimation that there might be carbon monoxide poisoning from the patient's immediate history. Have they been in a car where the engine has been running? Have they been in a confined space exposed to petrol or diesel fumes? Have they been in a fire where they could have inhaled carbon monoxide? Have they been found unconscious at home, especially during the winter months where appliances might have been burning gas and may have been burning it inefficiently and producing carbon monoxide? Is the patient tachypneic for no apparent reason? Because in carbon monoxide poisoning, even though the patient is breathing rapidly, their carbon dioxide levels will be low, but the amount of oxygen getting to the tissues will also be low because of the hemoglobin being all clogged up by the carbon monoxide. And we can also look for discoloration. Now, the skin discoloration and the discoloration of the lips in carbon monoxide poisoning varies from pink to red. So we're looking for pink or red discoloration. Now, this extreme pink we can see at the top is actually a post-mortem picture of someone who died of carbon monoxide poisoning. The picture of the hand below is a patient who was admitted with carbon monoxide poisoning but was alive and responded well to high intensity oxygen therapy. So a fairly simple clinical observation, but of course you need to think of it. And bear in mind always that the pulse oximetry is not going to help you in this situation. Now, of course, it's essential to realise that carbon monoxide poisoning is a life-threatening condition. But here, as Pathguy points out, it's easy to diagnose and treat if you think of it. But patients that die of it tend to have this pink to cherry red lividity. Now, lividity is caused by the settling of blood in the lower, that is the dependent parts of the body. And normally it causes a purplish or red discoloration of the skin. because when the heart stops pumping, the blood is no longer being circulated around the body, and the heavy red cells sink through the plasma by the action of gravity, and we get this lividity. So after a few hours after death, the top part of the body is a lighter coloured, and the lower part of the body is a darker colour. So typically bluish cyanosis lividity we would see, but in carbon monoxide it's a brighter reddish colour, and this is because of the presence of the carboxyhemoglobin in the erythrocytes. And here we see an actual example of post-mortem carbon monoxide lividity. Now this patient's been lying on his back. We can see that because the areas where the pressure of the body has been, the capillaries have been squeezed shut and the blood has been unable to settle into those areas. So they do not have lividity. And if we could see the surface of the patient's body, it would be a much whiter colour. So the red cells have settled down, causing this dark, what colour would you say that is? Some people say it's pink, some people say it's dark red. So pink to cherry red lividity, classic of post-mortem carbon monoxide poisoning, but of course, as we've seen, present in live patients with carbon monoxide poisoning as well. Perinatal hypoxia is hypoxia suffered by the child around the time of birth. So this could be during the process of delivery, or it could be just after the birth has taken place. And the neonatal central nervous system is very prone to hypoxic damage. So if there's perinatal hypoxia due to a difficult delivery or due to the baby not being properly oxygenated after birth, if they don't start breathing at an early stage, then there can be brain damage which can be irreversible. This can result in all sorts of permanent neurological deficit, such as cerebral palsy or lifelong learning disabilities, learning difficulties. So perinatal hypoxia is one we would want to go to extreme measures to prevent. Well, we know that oxygen lack first stops the machinery, and to begin with, the machinery will stutter and it will not be working properly. So the brain is usually the first organ where people notice the effects, especially of acute hypoxia. And the problem is, as a patient becomes hypoxic, they're unable to make sensible decisions because the brain itself is not working properly. And this has been a particular problem in aviation and in mountaineers, because you need the brain to be oxygenated for it to work properly. So saturations of less than 85%, the patient can't think straight, or the individual can't think straight, there's mental impairment. Then going on to severe mental impairment, and then when we get down to lower concentrations, the patient is going to lose consciousness. Obviously, we want to recognise hypoxia as early as we can. So, does the patient have depressed mental function and impaired judgment? Or irritability and restlessness and confusion? These can be signs of reduced oxygenation of the brain. Lethargy and excitement are somewhat paradoxical. So sometimes the patient can become lethargic, but other times there can be excitement, presumably caused by a form of cerebral agitation. And you notice this, if there's a reduced blood supply or a reduced oxygen supply to the brain, then the patient can become agitated and anxious. So if a patient is complaining of acute anxiety, do check their respiratory status, do check their oxygenation, and of course check for the possibility of the development of shock, because the brain might be hypoperfused. And of course, if the brain's hypoperfused, it's not going to be properly oxygenated either. So headache, nausea, dizziness, vomiting, fatigue, all possible signs of reduced brain oxygenation. Now, apparently, as the hypoxia becomes more severe, pain sensitivity can be dulled, but I can't really say I've got any direct experience of that. I'm not sure how true that is. But certainly when the hypoxia is severe, you can get convulsions, coma, and of course you will get death. The machinery will be wrecked. Convulsions you can get any time the brain is acutely embarrassed. So if someone becomes acutely hypotensive and that is prolonged, the brain will become hypoxic, and we can see fitting as a consequence of that. Now, cerebral edema can be a particular problem after there has been an acute episode of hypoxia. So, for example, if there's been a respiratory arrest where the patient hasn't been oxygenated for a period of time, or there's been a cardiac arrest where there's been no circulation of blood around the body. And of course, if there's no circulation of blood around the body, there's not going to be any circulation of blood to the brain, and there's going to be an acute hypoxia. And the response to this can be cerebral edema. And the cerebral edema will be the accumulation of fluid within the cranial cavity. There'll be a raised intracranial pressure as a result of that. And there's actually two mechanisms of cerebral edema. The first is vasogenic. So what happens here is when the brain is hypoxic, there will be a compensatory cerebrovascular vasodilation, and the blood vessels to the brain will dilate, and this includes the small blood vessels in the brain itself. Now, this is good because it's an attempt to compensate for the hypoxia. But if the blood vessels dilate a lot, especially if the capillaries dilate a lot, that will increase their permeability and more tissue fluid will be formed. So you can get a vasogenic cerebral edema because of the increase in the volume of the interstitial fluid in the brain. And the second mechanism of cerebral edema is cytotoxic cerebral edema. What happens here is that inside the individual brain cells, it runs out of energy, it runs out of the ATP. So the pumps on the cell membranes that pump out the sodium stop working. That means the amount of sodium inside the cells, the intracellular levels of sodium greatly increases. And of course, sodium is osmotic, so that's going to attract water into the cells. So as well as being an increased volume of interstitial fluid from the vasogenic cerebral edema, there's going to be an intracellular edema as well. The cells themselves will blow up, so-called cytotoxic cellular swelling. And both of these mechanisms are going to increase intracranial pressure. And if the pressure inside the brain is high, that means it's harder for the blood to perfuse the blood vessels that are in the brain. So that's going to cause a resultant cerebral ischemia. And very often these patients are unconscious. And it can take quite a long time for the cerebral edema to go down. So, for example, we notice that the vasogenic cerebral edema only resolves by slow diffusion. So the patient can have an acutely raised intracranial pressure for some period of time. And this means that we have to manage these patients very carefully, looking after our unconscious patients, to give the edema time to subside, to allow the perfusion to the brain to come back in again, so that we can assess our patients. And we do review them after 48 hours, but it may be considerably longer that it takes patients to recover from the acute cerebral edema, which might have been caused by only one acute episode of extreme hypoxia. So if the oxygen supply to skeletal muscles is reduced, they're not going to be able to produce energy as rapidly as you would expect. And we notice this when we go running. When we go running, our muscles get tired. Especially if we're running quickly, they'll get very tired because they're not getting enough oxygen. And this is often noted in chronic situations such as mountaineers who feel very tired and lethargic because their muscles aren't getting enough oxygen. It's perhaps not the sort of clinical feature that we'll notice so much in the acute hospital situation. But people will become very fatigued if they are hypoxic because they are unable to produce the energy. To produce energy, you need the oxygen, and you need the metabolic substrate, you need some sort of food-based fuel, and if you lack one or the other, you're going to feel tired. And also the patients are likely to feel very short of breath on exertion, especially if they're working at altitude in hypoxic environments. But this is also true in pathological situations. So for example, a patient with chronic bronchitis will feel short of breath on exertion, partly because they will become rapidly hypoxic. Now, it's very well known in acute care that if there's a reduced blood supply to the kidneys because of systemic hypotension, for example, then there is a risk that the kidneys will fail. There can be an acute renal failure, but there can also be damage to the kidneys. And this is the phenomena called ATN, acute tubular necrosis. And as I say, we normally associate this with acute hypoperfusion. But when you actually think about it, what the kidneys are probably running out of first is oxygen. So actually the acute tubular necrosis is probably caused primarily by the hypoxia. So we need to make sure that the kidneys are being perfused at all times, making sure the patient has an adequate blood pressure, but we also need to make sure that that blood is carrying enough oxygen to oxygenate the energy demanding cells of the kidney. Because the kidney is actually a very metabolic organ. It uses a lot of energy, it uses a lot of oxygen, and it also produces a lot of heat, making it prone to hypoxic damage. So quite how much of the acute tubular necrosis is caused by hypoxia, quite how much of the acute tubular necrosis is caused by the hypoperfusion, I don't really know, but I do know for sure that we need to keep kidneys perfused, and we do need to keep the blood which is perfusing those kidneys well oxygenated. The myocardium is obviously a very metabolically active tissue, and it requires a lot of oxygen, but it does have a reasonable anaerobic capacity. And this is presumably why people suffer the pain of angina pectoris. If the myocardium is hypoperfused, the aerobic metabolism in the myocardium changes from aerobic to anaerobic, and anaerobic metabolism is associated with the production of lactic acid. So the presence of the acidic lactic acid in the myocardium may well be the mechanism of pain that we get in myocardial ischemia and patients complain of in stable and indeed unstable angina. But if a patient's very short of oxygen, then in my experience, the problem is primarily the risk of dysrhythmias, that the heart goes into an abnormal rhythm. So what I've noted in patients who become very hypoxic is, first of all, they get more ventricular ectopic beats because the myocardium is becoming irritable, and then eventually they will go into a coarse ventricular fibrillation. Over time, that coarse ventricular fibrillation will become a fine ventricular fibrillation, and the fine ventricular fibrillation ultimately will give way to a systole. There can be bradycardic changes as well, particularly in children actually. If children are becoming hypoxic, they can become bradycardic. So a bradycardia in a child is a very serious clinical indicator and means that urgent action needs to be taken. And of course, we must always bear in mind what the normal heart rate is for a child of that age and calculate the bradycardia relative to their normal heart rate. But my experience with adults is the main risk is ventricular fibrillation. And this is true in acute respiratory disorders such as an acute asthmatic attack or a status asthmaticus. The risk is that the patient will go into ventricular fibrillation. This is why these acute respiratory conditions are immediate life-threatening medical emergencies.